everyone, and welcome to our ASN podcast on infection prevention. And today we are joined by Mr. Danilo Concepcion, who has been a dialysis practitioner since 1975, and he's currently the operations manager for renal services at St. Joseph's Hospital in Orange, California. Prior to entering the dialysis field, he was a corpsman in the Navy during Vietnam era, and he is experienced in the clinical, technological, research, and administrative areas of dialysis. He's been in the executive committee member and project committees for numerous dialysis-related organizations and is a prolific national and international speaker and writer and has been published in numerous professional journals and has been a contributing author for the Guide to the Elimination of Infection in Hemodialysis. He's also a member of the Renal Coalition for Disease and Detoxification Committee for Association of Advancement of Medical Instrumentation that develops the American standards and recommendation practices for dialysis. He's also a part of the Nephrologist Transforming Dialysis Safety Project Committee by ASN, as well as the Dialysis Safety Work Group for CDC Making Dialysis Safer Coalition. Thank you, Mr. Concepcion, for joining us today and sharing your expertise with infection prevention and water treatment systems.
Thank you.
So, I was reading through your involvement in the Association of Advancement of Medical Instrumentation, and I thought my first question should be about what are these AAMI standards that nephrologists and medical directors should know about, and how often do we monitor them?
Again, I've been in the AAMI standards for over 20 years. So most of the things that have been written and coming down the pipes, I've actually been involved with. And as far as water and dialysate, as you know, water makes up 94% of our prescription, which is dialysate. Being given 94% at 500 cc's a minute, typically, our patients are exposed to more water in 3 years than we could ever drink in a lifetime. So the exposure for that large volume makes it necessary for us to actually provide a level of quality that is safe for our patients. In AAMI, there are standards and recommended practice. Standards are written for manufacturers to follow. Standards for what components and how they're made for water treatment, for blood tubing, for concentrates, those are standards. For end users, there are recommended practice. Dialysate for hemodialysis and reprocessing standards. Thankfully, in our industry, reprocessing isn't done very often anymore. And so in the recommended practice, the progression or changes of those standards had dramatically changed since the initiation of the AAMI standards. In the beginning, 2,000 colony forming units was actually the level that was required for CFUs. For endotoxins, there weren't any unless you were doing reprocessing, which was at 5 endotoxin units.
And that was back in the day. And what are the current microbiological standards for bacteria and endotoxins that we need to be cognizant of?
Yeah, the current microbiological is based on a publication, RD52, which was published in 2004. And that is actually the guidelines that CMS uses for their references. Because CMS uses that RD52 2004 as their references, it becomes enforceable, meaning that it becomes a regulations. So it no longer is a recommended practice, it's now a regulation. If you were to read the standards, it said should, may, must. When CMS adopted those standards, all those shall, may are no longer shall and may. CMS makes it a must. So everything in that monograph is not must. The level of bacteriological count is at 200 for water and dialysate. with an action level of 50. For endotoxin, it is 2 endotoxin units with an action level of 1 for both water and dialysis. There are current standards now that have been updated since the RD52 2004. Obviously, that was a long time ago. So there are now current standards called the 23500.
Thanks for telling us about the AAMI standards and any comment on what we as medical directors and nephrologists need to know about levels of total chlorine
Mhm.
measurement? And do we even measure other things like aluminum, copper, fluoride? I get asked these questions, so I thought I'll ask you.
Yeah, not a problem. Well, there are things that each facility must be monitoring on a daily basis and on a continual basis. Um, and then there are things that you have to actually measure or monitor on an annual basis and on a monthly basis. Now, as far as an annual basis, you mentioned aluminum and things like that. Those called the AAMI standards or AAMI analysis. The AAMI analysis incorporates all of the contaminants in the water, in the feed water, and how well and effectively the RO system or whatever purification system you use reduces those to an acceptable AAMI standards. Those levels that AAMI standards set is actually a 90% reduction of what the EPA allows for drinking water. And that's the AAMI standards for chemical analysis. Now, as far as your monthly basis, you must measure culture and endotoxin monthly on your RO system and on your dialysis machine. The dialysis machine, if you're a large facility, becomes very challenging if you were to culture each machine. That becomes, again, challenging and expensive. So what the standards allows you to do is actually measure 2 machines per month as long as you rotate the machines so that each one is actually analyzed at least once a year. And
Mhm.
that's for both endotoxin and for cultures. On a daily basis, your staff need to monitor for your total chlorine, specifically for chloramine. Chloramine, as you know, is very destructive to red blood cells. It will hemolyze red blood cells. If it's not reduced to an acceptable level, which is less than or equal to zero point 0.1 per part per million, it could literally affect our patient's hemoglobin, and the resulting result would obviously be anemia if exposed too long. So that's done at the beginning of the day, every 4 hours if you can't designate shifts, and the other thing that has to be measured also too is your operating parameters in your RO system, continuing monitoring. One of the requirements is what they call TDS, total dissolved solids, which gives you how pure your water is. Typically, the cutoff for TDS in most facilities, in most RO system is you shouldn't exceed 50 parts per million. The lower, the better. Some facilities require that their system be less than 20 parts per million at any given time. If it's not, you have to look at why it's not delivering that kind of quality. Yep.
Right. So now that's a good point about, total chlorine monitoring and microbiological monitoring. So
Yeah.
let's say we reach the action level, right? The biomed person is checking a machine out and you have reached your 50 colony forming units. What should be done next promptly, and what are the next steps?
Yeah. And actually, believe it or not, CMS has put a definition of what promptly means.
Mhm.
Promptly means within 48 hours. That's actually in the CMS guidelines. So if your action level is at 50, okay, there is no AAMI standards, nor is there a CMS regulations of what you have to do. It just says those are the levels. There's nothing that says at 50, you must do this and this and this. That is the medical director's prerogative of what to do. And the reason for that is that Is it more detrimental to withhold dialysis on a patient that has a potassium of 8, but your total colony forming unit is less than 50? Knowing that the dialyzer is an ultrafilter that will not allow bacteria to cross over. So the medical director has to make that assessment as, okay, do I continue dialysis or do I have my biomed pull the machine and fix it? So, so that's the action level that you can do. Typically, action level requires you to disinfect the machine, wait 48 hours, reculture it, and see if it's still above the action level or below the action level. If it isn't, you can put it back in place and then monitor it again the week after, not the month after, because you don't want to wait that long to see if your action is actually effective. And if it is okay at that week, you can go ahead and analyze it along with the other machine next culturing schedule. Obviously, if that same system comes back positive, you got to do a deeper investigation of why is this one being so problematic.
Gotcha. No, thank you for reinforcing that promptly is within 48 hours. And that's what we normally do. We reculture, disinfect, pull the machine out, and make sure that we are within AAMI standards. And you said it could be a recurring problem, and in the water systems, there could be issues around stagnation of water in the pipes. How do we tackle that, or how do we prevent water stagnation? Because, as you know, eventually that could lead to biofilm, and that
Yep.
is the level of discussion.
Okay, there's only two ways to prevent that kind of stagnation. The first one is the biggest one. Design your system so that you do not have dead legs and stagnation points in your system. That is focus number one. Design it correctly and maintain it, and you won't have any problems. So that's the initial problem, is bad design. The other is that we have two types of systems. We have a direct feed system and an indirect feed system. An indirect feed system uses a holding tank, and that holding tank has distribution pump that actually circulates the water throughout the whole system continuously without any pause. In a direct system, the RO system itself is the distribution pump. So when the direct feed system is on, the loop is being flushed, or I say there's a continuous flow to that. When the unit is not being used for treatment, most facilities turn that system off because it's a waste, because everything is going down the drain that you're making. So depending on how long that gap is, that could be a stagnation time for that facility. And some places actually put some method of actually flushing it routinely automatically, which the new systems are not capable of doing.
Yeah, no, thanks for telling us about the continuous flushing and the timed flushing of the pipes in order to ensure there is no stagnation.
Yeah.
Just to clarify, you mentioned dead legs in pipes, and to our majority of your audiences, some of them may be fellows.
Sure.
What are the dead legs in the pipes?
Okay. Yeah. So in the design of the water loop that distributes water to each station, you've got one continuous loop. And from that loop, you actually connect a port to feed your dialysis machines at each station. The segment from that loop to the end connection of that water loop to the machine, that is a segment that could be considered a dead leg. So the requirement is that in your design, you actually design that connection from your water loop as minimally as much as possible. There are some debate as to how long a dead leg can be. Some say 3 times the diameter of the pipe, and some say others. But again, the onus is keep it as short as possible because it is a stagnation point.
Right. So the key point, I think, for the listeners, like you said, the dead leg is the stagnation points in the pipe. And we're trying to avoid stagnation because that's the prime area where a biofilm would form.
Yes.
Coming
Exactly.
to our next problem, Mr. Concepcion, how do we deal with a biofilm?
That is a question again that has cost facilities a lot of money. Unfortunately, once biofilm has actually embedded itself in the system, there's almost nothing that will reduce it except for harsh chemicals and ozonization. Ozone will actually eliminate biofilm, but most old facilities have PVC pipes running through their facility. PVC will not withstand ozone. So they're using hyperchlorinization. Hyperbleach concentration will remove some of it, but it doesn't get rid of all of it because a biofilm is so protective that it's sometimes even a hyperchlorine concentration won't get into every aspect of that biofilm. So the other process and procedures is you replace the piping.
Okay. And may I ask, what is the utility of UV irradiation?
UV irradiation is used, you can use that in several places. You can use it before your RO, after your RO, and when it returns. UV actually, in a certain wavelength, it has to be the correct wavelength, will actually kill bacteria and keep it from reproducing. Yep.
And you also mentioned, routine disinfection of the system, which is essential, so we don't have biofilm formations.
Mhm.
Could you go over some disinfection practices that we normally have in our water systems for our audiences?
Okay. Again, most facilities disinfect their RO system on a monthly basis. If your cultures come back positive, culture does not tell you that you need to disinfect. What the result of the culture tells you is that what you are doing to control bacteria is effective from month to month. So if you're disinfecting once a month and you continuously have a history of bacterial proliferation, it's telling you once a month is not enough. So you have to adjust your disinfection to possibly every other week.
Mhm.
And if every other week gives you your monthly results that you are controlling bacteria, perfect. You stay with that schedule. But if you continuously still have results in that every other week, you need to adjust it maybe once a week.
Mhm.
So it tells you, doing cultures tells you that your disinfection is adequate. And most facilities do two chemicals to disinfect their system. The loop, a lot of facilities use bleach because they're not disinfecting their RO system at the same time. There's a method to do that. And most facilities use what they call peroxyacetic acid, which
Mhm.
is Mincare or Micro X, and that can be used in the RO system and the loop at the same time. So you're disinfecting everything at the same time. Current machines nowadays are doing it by heat at greater than 80 degrees centigrade. So those are the three methods of disinfecting.
Right. And yeah, thanks for bringing up the heat disinfect and the chemical disinfect. And I believe there are these dual disinfection systems as well. Uh,
Mhm.
any problems that are unique because of heat disinfection in the water system?
No, not with the heat. As far as bacterial control, what is the beauty of heat is that you can do it frequently. We do once a month annual chemical disinfection because of the labor, because of how long it takes, and when you have to do it. You can't do it when patients are on the next day because it's a prolonged process. So most facilities typically do it on the Sunday when they're closed. With the heat disinfect, you can do it every night, just like your dialysis machine. And
Mhm.
with dialysis machines, we have no problem with bacterial growth or bacterial control. Yeah. So that's the beauty of heat.
And what about filter maintenance? Like what should be our protocols for maintenance of filters?
Okay, manufacturers have their instructions of how often you should change the filter, whether it be an ultrafilter or whether it be a sediment filter or a pre-filter. Those have instructions from the manufacturer, but those kind of filters actually is measured also continuously, but by pressure gauges. So if your pressure gauges has a delta pressure, meaning that your incoming pressure and your outgoing pressure in that vessel, that filter vessel is 10 psi difference, you should investigate why it's 10 psi difference, and you may have to replace it before the schedule changes. Yeah.
No, thanks for telling us about the maintenance and inspection. But what steps or training and protocols staff should take in order to prevent infections in the water system?
Now, as far as infection in the water system, with the elimination of almost elimination of reprocessing, infection from water system is relatively unheard of nowadays. What you will have is inflammatory responses if your endotoxin level gets too high. So in reality, medical directors and physicians shouldn't be involved, shouldn't be concerned about the culture itself, but by the endotoxin level, because there's a relationship between the endotoxin level and the cultures. As you know, like I said before, bacteria, viruses, organic compounds, organic materials such as those cannot cross the dialyzer membrane. So if the dialyzer membrane is blocking everything from the dialysate getting into the blood, that's not your concern. Endotoxin is. So if I were a physician, my personal opinion, I would be focusing on endotoxin, not cultures. Yeah. And yeah, go ahead.
And any comments on the disinfection protocol documentation, which the staff and the nurses have to do,
Yeah.
um, just to keep clear of all the records of when disinfection happened, how
Yeah.
important.
Yeah, documentations of all your testing, whether it be cultures or endotoxins, is one of the things that is actually surveyed by your CMS or Joint Commission, depending on whether you're a hospital based or subject to Joint Commission. But cultures and endotoxins, your daily logs are actually analyzed to make sure that the medical director is intimate with all those results. They have to show their involvement with those records. They have to show that there's a trending being done. They have to make sure that the action level is being done according to that. And also, too, one of the things that gets checked is when is disinfection done in relationship to when you're culturing? Because if you were to disinfect and the date showed that you cultured the day after, that's a citation. So those kind of things are being looked at as far as documentation is concerned. Trending, timing, and involvement of the medical director.
That's very good to know for all our future medical directors out there.
Mhm.
Some words of wisdom. He's telling you what you should be on the lookout for. And in my practice, I used to always tour the water system facility myself whenever I did the quality meeting and I signed off on the documents. And
Yeah.
thanks for
Yeah.
sharing.
Yeah. And as far as training, CMS requires that staff involved in water treatment be trained annually or competent annually. Okay, just to let you know, my medical director has to go through the same thing that my water guy has to go through. I make them go through it. Our physicians.
Well, that's good practice because we're all working as a team and patient safety is a priority.
Yeah.
So speaking about mishaps, how to deal with the water treatment system malfunction or a quality issue. I'm sure you've seen most of the problems.
Yeah, again. Because dialysis is one of those things that is not critical if, well, it can be critical in some situations, but in an outpatient setting, if you have a delayed of treatment, it's not catastrophic. So most facilities do not have a backup system or method of emergency water supply. What they do with a situation where there's a prolonged downage of your water system is to actually send them to their affiliate agreement facility to dialyze at those locations. In my facility, what we've done is we don't want to do that. I actually have two independent systems that's capable of actually doing the job by itself. So if one goes down, guess what? I have a backup. So I have a backup for my RO system, and so we don't have that problem. In emergency disaster situation, some facilities have it set up so that they can actually bring in emergency water and actually hook it up to their distribution or to their RO purification system. Again, not every facility has that.
Where do they get that emergency water from?
Okay, you can get it from several places. You can rely on local EMS, emergency management system, if they have it, because they have tankers available depending on, again, your locality. And the other is that you can contract with vendors to supply you water. Yeah. And the third is that the two LDOs, I won't mention their names, the two LDOs actually have a fleet because we learned a lesson in Katrina that actually have a fleet of emergency generators and emergency water. Whether or not in your situation that they would allow you to actually use those, that's a debate and a discussion for your facility and the DaVita, excuse me, the LDO leadership that you may want to open up.
No, and I mean, this does happen. We have had instances where dialysis facilities have had to still function with the use of tankers because of natural disasters. So it's an important point for sure.
Yeah, now if there is no problem with your water supply, but your RO system isn't working, there is a secondary method of supplying water to your facility, which is called DI. Some places have that as an emergency backup. A deionization system are a purification tank that exchanges ions, cations, and anions to produce pure H2O. Deionization, DI water is actually more pure than RO water.
That's what we use in our facilities. We've had backup DIs, but it's very labor intensive to run a DI.
Yeah, and it can be dangerous.
It's time limited.
Mhm.
What about chloramine breakthrough? You talked about those carbon tanks, and that is, what steps should we employ if there is a chloramine breakthrough?
Okay. The requirements for checking it every 4 hours, the configuration required by AAMI and CMS of series redundancy, hopefully will mitigate that issue and problem. But if it does, because again, if your carbon tanks are undersized, and if you change your RO system so that it's using more water and you don't adjust your carbon size, those are can be problematic as far as chloramine breakthrough. Now, chloramine breakthrough, again, it's a prolonged exposure to the patient that will harm it. So if, say, for example, first shift is good and then fourth shift is bad, you know that your patients haven't been exposed to a very prolonged concentration because the concentration is typically not that high. It's just dangerous because it's an overexposure for a prolonged period of time. There are things called false positive. It's called organic chloramine. That makes your water look like it's positive for chloramine, but in reality, it's not. When you have too much organics coming into your facility, you may be changing your carbons frequently because you keep getting positive results. What's happening is the bacteria and organics coming into your tank is actually catalyzing with the carbons and the chemicals inside that carbon and making producing its own chloramine. But that chloramine is actually attached to organics, so it'll go through your carbon and test positive. But if you test your RO water, your purification, organic chloramines won't go through your RO system, so it would be negative. So that's how you differentiate it. But again, undersizing when you increase flow or not calculating correctly your carbon size and not having the serious redundancy would be the problem of chloramine breakthroughs.
And how should we manage it?
How you manage? Again, look at the design, make sure that everything is placed, make sure that if you have organic coming into your system, that you put in place an organic scavenger in front of your RO system. So those are the ways that you can actually mitigate and prevent those issues.
Thank you. That's changing the carbon bed is essential. And
Yeah.
you have written this book on elimination guide in preventing hemodialysis infections. So tell us a bit more about your work and what should we be doing differently apart from everything else that you've mentioned about stagnation and biofilm prevention and treatment. What else
Yeah.
doing?
Actually, what we discussed about and the things that I've said are actually what is in that book. How to culture, when to culture, the limits and the levels. Those are part of the APIC elimination guide for preventing infection in hemodialysis. Along with that is some of the environmental disinfection that I actually helped write in that publication. So everything that we've discussed is actually what you should be doing and needing to follow to prevent infection in your patients. Like I said, with reprocessing gone, culture, I've not seen any type of blood contamination or sepsis due to water systems. I've seen inflammatory responses, yes, but not infections. Yeah.
That's good to know. And question about, what should a home dialysis patient do in terms of water treatment and best practices?
Good question, because there is a difference. There are some differences in home patient system and in an outpatient system. Um, Today's technology, now there are things called pre-configured system. A pre-configured system is one that has the water system that is part of the dialysis machine. For example, you have a system that has am I allowed to mention the names? I don't know if that I'm allowed to mention names or not. But anyway, there's a system that actually has two methods of delivering dialysate, either by bags or making bags with the water system that's associated with that machine. And then there's a new system that has a demand system that has an RO system, but you use concentrates and not bag, but is a pure demand system. Those are called pre-configured system. The allowability of culture for those, again, the same level is required for home patients. But the big difference is the frequency of testing. In a home setting, CMS and AAMI actually has a clause in exception that you can do those on a quarterly basis rather than a monthly basis.
Mhm.
Yeah.
Yeah.
And stagnation, again, is a problem too, because again, you have this RO system that if you're doing every other day dialysis, it's stagnate. So the critical thing is that they follow the specific instructions of when to disinfect the system and make sure that your biomed is testing appropriately and at the right schedules and analyzing and looking for trends in the home patients. Yeah.
And any issues with disinfection logs or training with the home patient or any differences between in-center versus home?
Well, you're relying on the home patient to do the documentation and logging. So when you're relying on the patient, guess what? You may have some lapses and some issues and problems in obtaining those. So, but with cultures and endotoxins and things like that, the beauty of it is not getting the reports, but actually having it done. So if your patients are actually the ones that are obtaining those samples, that could be problematic. My facility, we send my biomeds out to go take those cultures to eliminate that possibility. Also, too, remember that if you're just using that one system's bag system and not the system that makes the bags, you don't have to do cultures.
Hmm. That's good to know. And and thanks for like sharing the differences between the home dialysis setup and the in-center setup. Because everyone is now learning about home dialysis even more.
Yep.
Any parting words of advice for our viewers on what infection prevention best practices we should be adopting? We talked a lot about the water system, but in the beginning, you were mentioning about practices in the in-center facility about how we decannulate and cannulate. Any
Yeah. Yeah, I actually, in the early days, in when I started, we literally would betadine our thumb and hold it over the site to stop it from bleeding. We did those practices. We had patients actually sitting in their chairs, helping us with doing clotting times with Lee White, and if most of your fellows are not even going to know what Lee White is Lee White is actually clotting time where you take a sample of blood and tip it on a routine basis and a time basis until it clots, and that's your clotting time. We had patients doing that in their chairs. So the possibility of exposure there obviously was high in degree. The progression of today's infection control policies addressed all our shortcomings and all the things that we learned was, we shouldn't be doing that, is now in place. So we kind of paved the road for you for today's practitioners with all the things that we learned way back then. Yeah, even conductivity meters. Well, our conductivity meters was our tongue because we didn't have conductivity meters. So we would literally taste the dialysis, see if it was salty.
Oh, wow. Oh, that I did not know that. And
Yeah.
that is another issue is a conduct. But no, thanks for bringing that up.
Yeah.
No, it has been a pleasure, Mr. Concepcion, having you over this podcast and going over, words of wisdom with regards to water distribution,
Yeah.
uh, safety, and infection prevention.
That's
Um,
it. Design it right, keep it right. Those are the two key words.
and you've heard it, design it right and keep it right. Thank you, Mr. Concepcion.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.